Welcome back to our journey with Michael Bourke, colorectal EMR, colorectal lesion assessment. We have been talking about the colon in the previous sessions, images, risk assessment. Now we're going down to an almost different organ, the rectum. So what's different in the rectum, Michael?
Yeah, so the rectum, historically, we always thought of the rectum and the colon as one continuous organ, but really they're not at all. And the rectum is very different to the rest of the colon. In fact, the sigmoid in the rectum probably different to the rest of the colon. It probably relates to the dwell time with stool, but the risk of advanced disease is much greater, and the assessment of lesions is much greater. So much more challenging, but it heads in a different direction. So, for example, in this study, we looked at 3,400 laterally spreading colonic lesions referred to us over a period of more than 10 years, all greater than 20 millimeter. And we divided them into rectal lesions versus non-rectal lesions, 600 versus 2,700. And the risk of cancer in the rectal lesions is 15% versus 6.2% in the colon. So this is a 2.5-fold difference. And in fact, when you look at other parameters, lesions in the rectum tend to be larger. They tend more to have B1S or 2A plus 1S, in other words, nodular or mixed nodular, more often granular, more often advanced kudo patterns, 4 and 5, and more often adenomas. And it's nicely summarized here in this table, where you see that in the rectum, 72% of lesions were tubular villus adenomas, as opposed to the colon, it's only 46%. And high-grade dysplasia was present in nearly 1/3 versus only less than 20%, and cancer in 15 versus 6.2. So these are orders of magnitude of 1.5 to 2.5 times in the case of the colon, in the case of cancer in the rectum. So it's something that we need to consider when we're evaluating lesions, because, as I said before, colonic lesions, when they're flat, we can tell what's going on. But in the rectum, lesions are not often flat. They're more often nodular, mixed nodular. So we can't be certain what's going on. And also the risk of cancer is much greater. So we have to bear that in mind when we're choosing our resection strategy. So here's an example of a lesion in the sigmoid. It's a flat lesion. So we can carefully evaluate to check for evidence of invasive disease. So it's a flat, non-granular lesion. So it's non-granular, it's in the left colon, distal left colon, rectum, it's in the sigmoid, higher risk. And then when we look centrally, we see a disruption of pit and microvascular pattern. And so we can follow the pattern in from the outside here, if you look in the central image, and then here, centrally, we can't see a discernible pattern, no discernible pattern. And again, irregular pits and vessels and subtle depression. So this is at least high-grade dysplasia, most likely superficial submucosal invasive cancer.
But is there such a difference if you would find this in the ascending colon? That also looks ugly there, right?
It does, yes. If we found this in the ascending colon, we would say this is a cancer and we've got to resect it. But they're not that common. Lesions like this in the right colon, you don't see them.
So it's about the frequency? Because I was also assuming that, you know, nodules and stuff are treated differently in the rectum. So
we're going to talk about nodular disease in a moment, and the whole approach is different, right colon versus rectum.
So the features of those flat lesions,
this is overt
cancer, are the same, but they're more frequent. You have to reckon with them more frequently.
Yeah.
So if you don't find them, look more carefully in the rectum.
In flat lesions, yes.
Yes. Okay.
But they may not be present. And if they're not, then it's at your discretion. You could do piecemeal EMR if you're experienced and you're confident. So this lesion very definitely has to be managed by en-bloc resection, and so we do ESD. It's a paradox that ESD in the colon, in my view, is a lot easier than the rectum because the lesions are smaller and there's no bleeding. And the rectum, we have massive lesions and there's a lot of bleeding. No matter what you do, even as careful, blood vessels are large, especially distal rectum. So colonic ESD, safe, but a bit more time consuming. And this, of course, this lesion was cured. This is a de-identified data, but no special type, adenocarcinoma, margins clear, background tubular adenoma, patient's cured. And
this ugly lesion,
Yeah,
Okay.
yeah. Well,
Yeah.
according to the pathologist.
Well, we have to believe something.
Yeah, yeah. It's this lady was 80 odd, very happy, saved an anterior resection, which has, of course, a lot of problems. Depth of invasion was 0.454. Sometimes we look at a lesion like that, it's just high grade. You know, I think it's not, you know. So this is a different example of covert cancer or risk for covert SMIC because it's a risk. Because the lesion is in the sigmoid, it's a nodular lesion and it's non-granular. So based on our data, the risk of covert cancer is around 20% in a non-granular lesion with a nodule in the sigmoid or rectum. So therefore, we would do ESD in this situation.
Even if the morphology might be the same, because you don't see any high-risk features there on both the
Versus the
nodular
right
and
colon, you're
granular.
saying?
Yes.
Yeah,
Yes.
yeah. Because in the right colon, if we have this sort of, well, this lesion's not common in the right colon.
But even if so, you could risk an EMR.
You could risk an EMR. We might do ESD or we might go for en-bloc EMR. Yeah. Sometimes we take a huge snare, make a huge injection. But here, sigmoid, you know, we can easily do ESD. Yeah.
Okay, Michael, we want to have more images. So rectum.
Yeah. So here we have 9 different examples of, I would say, fairly typical lesions that you see in the rectum. They tend to be granular. They tend to be mixed nodular, and they tend to be large. They're often larger than 4 centimeter, and they have an ugly appearance. You know, like for example here, and partly that might relate to trauma from defecation and prolapse, particularly if they're on the anterior wall. You know, which is where solitary rectal ulcer syndrome develops, and they can have fibrosis if they're close to the anus on the anterior wall from prolapse and that sort of thing. So they're hard to evaluate, and then we also know that the risk of cancer for all lesions is greater. It's 2.5 times, and then particularly if they're nodular, not flat, the risk of cancer is also escalated. So in that situation, the way to assess these lesions is just as we discussed, using the same platform. So overview, are they homogeneous, or is there disruption to pit or microvascular pattern? Can you see any major depression or major nodule? Look carefully at the nodules and the depressed areas. But often at the end of all that, having looked at all these lesions carefully, you're still stuck with a lesion that's mixed nodular, no overt expression of cancer, but we know for sure that quite a proportion have cancer within them, probably somewhere between 10 to 20%.
So the careful assessment we were discussing in the previous episodes in large lesions in the right colon or the proximal colon is not so important, because, you know, the risk is elevated anyway, and management-wise...
It's still important, but but it's not as useful.
It's not as useful. But, you know, in the proximal colon, if I may oversimplify, you really try to exclude suspicious areas that you can go ahead with EMR.
Yeah.
Here you would have to be even more careful and still hesitant to select those in whom you still could do EMR. So
yeah. So
and well, can we learn a little bit more? So the left lower lesion, is that an EMR lesion?
Well, the answer, so we do MBI, all of those things, but the answer is they're all done like that.
And they're all cancers?
No, they're not. But there's a chance they're cancer. And the problem is that if we make a mistake in the rectum, the patient is looking at a major operation. And of all the cancers that occur in the rectum in a referral population of large, you know, non-pedunculated rectal polyps, then probably of all the cancers, which is, you know, of all lesions, it's around 15% you just saw. And of those, about half of them are early cancers, which can be cured by en bloc resection. So,
or even more with expanded indications and expanded techniques. So that's, I think the old oncologic boundaries are not valid anymore.
No.
So you could curatively, maybe with adjuvant therapy, curatively resect even more in the future.
Yeah.
Probably.
Definitely, because I can show some other examples, but if we're going to talk about resection, but um, if you have an R0 resection and the tumour is, say it's LVI positive, it's got lymphatic and venous invasion, but the MRI, there's no nodes, then if you send that patient to the multidisciplinary team meeting, sensible people will say, well, if we remove the rectum, there's probably no indication the patient's going to be any better off, because we're not worried about local recurrence. We're worried about lymph nodes and distant disease. And this is the same argument in the esophagus. So upfront, major invasive surgery, it may not be a benefit. And that's the beauty of complete resection of the primary tumour en bloc and R0, because it's potentially curative and it informs subsequent treatment decisions without the morbidity of upfront surgery.
Okay, I get that, but I must push you a little bit. So there's very little place for EMR unless it's a flat, granular, rather smallish 3-4 centimeter type of lesion in the rectum.
Could be non-granular too, provided you're confident, but they are not so common in the rectum. So they're generally flat, granular lesions, and we would do EMR for those if we look carefully, we're not concerned.
So if you go back, maybe 1 or 2, so none of those back? Yeah, none of those you would even attempt with EMR.
None of these lesions have been managed by EMR today.
And you would not recommend it?
I 100% do not recommend it.
Okay.
I think, so for rectal lesions, it becomes quite subspecialized, and, you know, they need to be managed in a center where all options are on the table. And you're doing these cases frequently. You have, you know, 1 or 2 of these cases each, you know, 1 to 2, 3 weeks.
But again, little role for EMR.
Very little role. So we do EMR in the rectum 10 to 15% of the time now. We're mainly doing ESD.
And which lesions are you doing with EMR?
Just flat granular lesions, or if they have a small nodule less than 10 millimeter. Anything we can be certain there's no cancer, then
So
we do
those-
EMR. So we did. I can go to a study where we looked at it. Do you want me to show that?
Those in the proximal rectum, which we have discussed in the last episodes, you would take a size limitation and you would take the very obvious benign ones in the rectum, perhaps with EMR.
Yeah, we do EMR in the rectum, but mainly ESD.
Okay, good.
Up until, you know, 2015, 16, 17, you know, people were divided into EMR and ESD people, and the twain shall never meet. But as we increasingly worked it out, and we've been doing ESD in the upper GI since 2008, I saw that there was a very good role for ESD in the colorectum, but particularly the rectum. And we did this study where we looked at a rectum-specific algorithm for endoscopic treatment of large non-pedunculated rectal polyps. And we enrolled 480 patients. We had the universal EMR algorithm from before, so that was 290. And then 190, we did selective ESD. So at that time, it ended up being about, in the selective algorithm, about half and half EMR ESD. Now, these days, it's much less EMR. But this is an example.
Because of?
Well, in that study, every cancer that could be cured was cured, which was 30% of all the cancers from 2017 on, by criteria. But increasingly, we've just got this bias towards doing ESD because we don't want to get caught out. But we didn't miss a single cancer for cure. Just by doing ESD whenever there was a mixed nodular lesion or anything larger than 10 to 15 millimeters, we do ESD. So this is a good example of a patient with 2 lesions, this bulky lesion here and this flat granular lesion here. Now, if you assess the flat granular lesion first and look carefully and you see no evidence for invasive disease, this can be done by EMR, and of course we always do snare tip soft coagulation in the margin, which reduces the risk of recurrence to low single-digit figures. And then subsequently, same procedure, this bulky lesion, which is hard to assess, could have some early cancer within it, no surface expression of early cancer. In this case, we do ESD, same day, same session. This exemplifies the problem with rectal ESD. The vessels are large. The huge vessel here, if you nick that, you're going to lose 5 minutes stopping the bleeding. So there's a lot of device exchange in and out with the knife versus the coagulation forceps and so on. So it's time consuming. And rectal ESD, I think, is more difficult than colonic ESD, actually, although it's probably safer in terms of perforation, and certainly more difficult than esophageal ESD. But this is the approach. So,
And what was the histology?
this is just a TVA, both TVAs, yeah. So 4/5 of them won't have anything too serious in them. But for the small percentage that will, you don't want to have done piecemeal resection of that early cancer when the patient is looking at a proctectomy if they go to the MDT.
So actually, if I try to summarize the rectal experience as opposed to the colonic, in the colon, it's more, or colon versus rectum, it's about frequency. If there's low frequency, that's one argument. In the colon versus the rectum, it's a higher frequency. So to do more aggressive things like ESD in almost everybody. Plus the subsequent surgery is much easier in the colon than in the rectum.
Yes.
And these arguments override the morphologic assessment, and could this nodule be here and there, and right? More or less.
They do. In fact, when we look at all the data, if you divide the colon just from anatomically based on embryological principles, and you say splenic flexure and proximal versus distal to splenic flexure, then the risk of cancer in the colon, splenic flexure and proximal, is only 4%. And on the other side, it's up to 15% in the rectum. And also, what's the proportion of cancers that can be cured? And when cancer occurs in the right colon, it's almost never early stage. When we looked at thousands of cases, there are only 20. So it worked. We did the maths on it, and we haven't submitted the paper yet, but you have to do something like 140 ESDs to cure one early cancer in the right colon. That's proximal to the splenic flexure. Versus in the left colon, particularly rectum and sigmoid, you probably have to do 10.
Plus subsequent surgery is very, very different. Huh?
Well, that's right. With ERAS, rapid recovery protocols, you're out of hospital with a right hemicolectomy, you're out of hospital in 3 to 5 days. And rectum and low anterior resection, you're looking at sexual dysfunction, urinary dysfunction, stoma, permanent kidney damage if you have a stoma-related renal impairment, lots of different things, and mortality, morbidity, much, much greater. So, and leak rate, the leak rate is 20%. And if you have a leak, you're in hospital for...
Yeah, I know. But I like the simplified clinical criteria, other than just obsessively relying on images, and this is the image which looks like that. So it's the image gives you a risk assessment, but the location, the size, and the clinical consequences of subsequent surgery
always have to be factored in.
Yes. Wow.
Yeah.
Okay. So that's a good conclusion. ESD in the rectum almost always, and most instances of larger polyps above the splenic flexure can be cured by EMR.
Correct.
Thank you.